problem in Parkinson's disease is that the neurons are not communicating properly because they don't have enough of the fuel, if you will, to make those communications smooth, dopamine. And so they get this abnormal electrical signal in the brain that we can block or alter in some way with an electrode in the brain.
Welcome to Baptist HealthTalk, a podcast on all things healthcare, powered by Baptist Health South Florida, your trusted source for healthcare prevention and wellness.
I'm your host, Willard Shepard, and welcome back to a new episode of Baptist HealthTalk, where we answer the questions that you searched the most on trending topics. Today, we're discussing a life-changing procedure that is restoring hope and improving quality of life for patients who have Parkinson's disease. We are joined by Dr. Justin Sporrer, Director of Functional Neurosurgery at Baptist Health Miami Neuroscience Institute, and Baptist Health patient Anna Velasco, who is living with Parkinson's disease. First of all, thanks to both of you for being here. And Anna, I want to start with you. Just tell me some about your journey and how you ended up coming in contact with the doctor and how he's been able to help you.
Well, I started this journey 11 years ago, and I ended up after several doctors in different hospitals. I ended up with Dr. Torres, and gladly he introduced me to Dr. Sporrer, and that's how we started, basically.
Initially, what was going on? What did you see? You know, those of us that are lay people think about tremors, those types of things. What was the first thing that caused you to say, hey, look, I need to have this checked out?
Honestly, it started the twitching in my eye. Like when you're stressed that your eye twitches, that's how it started. Then my finger, my arm, my leg, and that's how it started going on and not stopping, to the point that I had to see a neurologist. And that's when he said, you have Parkinson's. I did that scan and MRI, like a type of MRI. And that's how they said, yeah, it's affirmative. You're positive. You're a patient of Parkinson's disease.
Doctor, I was telling you that my father had Parkinson's disease later in his life, in his 80s, and I witnessed some of this. Educate us about this disease, its inception, and does it actually affect people as they get older?
So Parkinson's disease is a complex problem. And in fact, these days there's a push to call it Parkinson's diseases because no two people are exactly alike. But basically, it's a neurodegenerative disease, meaning that there is a population of neurons in the brain that are dying off more rapidly than they normally would. Some of that is associated with age naturally. And so if we tend to move a little bit more slowly as we age, that's normal. But in people with Parkinson's disease, they're losing those neurons that allow us to have smooth movements, to move quickly and easily, much more rapidly. And so the kind of quintessential symptoms, I use a mnemonic TRAP, which is tremor, rigidity, akinesia, which is lack of movement, and postural instability or imbalance. And so if somebody has 2 or 3 or all 4 of those, I'm very suspicious that it's Parkinson's disease.
So now, Anna, tell me how this impacted your life on a daily basis.
Oh, wow. Everything. You got to the point. The things that you don't know how much you need to do with your movements until the moment you are missing it. I couldn't brush my teeth. I couldn't wash my face. I couldn't get dressed. I couldn't tie shoes. I couldn't eat soup. I couldn't eat rice. I couldn't do so many things. My work. It affects every single way of your life. The sports, I used to ride bicycle all the time, and I couldn't do it because I had no balance. So it's hard. It's not a good way of living. There's no way of living with Parkinson's.
Okay, so when you first saw her, tell me about the diagnosis and then the steps you started to take.
So Anna mentioned meeting with Dr. Torres, who is one of my partners and a movement disorders neurologist, and they are instrumental in making the diagnosis and determining who might be a good candidate for my services, which are surgical, like deep brain stimulation. And so when I met her, she checked all those boxes that we just talked about, with the tremor and the rigidity. She was also describing pains, which are associated with something called dystonia or abnormal contraction of the muscles, difficulty walking. And she had tried and failed medications. There's two ways to fail medications. Either they don't work or they work and you're having too many side effects, which essentially makes it ineffective because you can't take it. In her case, I believe, she was having nausea. And so, if you've ever been nauseous, there's really nothing really worse than that. And so she just avoided taking the medication and was left with very few options. And that's where we were able to step in, evaluate, and offer her deep brain stimulation.
We were talking very briefly about the medications, and I know my father would say to me, wow, I take it, I'm very tired, I'm lethargic, I don't feel like doing anything, I take the medicine, the tremors stop. Where have we come with these types of medications, oral medications?
So the medications, luckily, have actually improved over the past 2 decades or so. If you go back that far, or even 50 years ago, it was really, you could take dopamine. And so then that graduated to maybe 5 or 6 different medications. Now it's over 24 different medications, which that's why it really requires an expert in movement disorders and Parkinson's disease to help manage that. The truth of the matter is that the neurosurgeons are getting less referrals for deep brain stimulation because the medicines have become more effective. And that's wonderful. Ultimately, the surgery and the surgeons might be put out of business, but that's okay if we have a group of patients who are feeling that much better. But there's always going to be, I think, a subset of people who are not responding well to those medications, or who have to take it so often that they feel, these side effects of too much medication, and then the lows of not enough. I mean, we have a metabolism that, you can't keep, it's hard to keep, rather, a very consistent level of those medications in the system. And that's where deep brain stimulation can help.
Okay. Anna, tell me about your experience here when you came to the facility and you met Dr. Sporrer, and how they walk you through this process and some of the decisions that you had to make.
Well, it was funny because I saw him and he was so young. And that was the first thing.
He's young and handsome.
What can I say?
I didn't think about those moments. You don't think if that person's handsome
and
or not.
smart,
But
which is most important in all of this.
Oh, he's young. But I guess I did some research, and he was extremely qualified. And I said, okay, this is it. So we talked. There was a good bond. He explained everything. And I was already decided. Because I think a lot of Parkinson's, what affects you, it's your brain. It's like if your mind's set to do something, not only Parkinson's, in life in general, you do it. So we talked. They said, yeah, you are a candidate. Let's do this. We did a couple of tests. And then it went. And that's how it went, everything. And then I got in the OR, and I was like, oh, Lord.
What had your family been saying to you? What kind of conversations had they had with you?
Well, at the beginning, they told me I was insane. And some of them didn't agree because it was too invasive. Mm-hmm. But when they saw me, they were like, oh, my Lord, it's perfect. It's been, honestly, it's more what they say of what really it is on your body. And again, we go by your mindset. If you decide to do something, you're going to make it easier, right? If not, you're going to make it worse. My mind was so set to have it done and get alive that it was smooth. It was a smooth ride for me. Actually, during the operation, I don't know if I can say this, but he was turning it on. He goes, do you want a tissue? And I said, a tissue? What for? Because most of the people cry. I said, no tissue. You just don't turn it off. Don't turn it off.
Let me ask you big picture before you describe exactly what you did and where you are with this technology now. Of 100 people that come in and you make a diagnosis of Parkinson's, how many are actually candidates for this?
Well, I'm in a lucky position because a lot of people have already been vetted by their neurologist to determine whether they are a candidate for deep brain stimulation. It is quite a workup, and it is not to make it harder on the patient. It's to ensure that they are going to get a good benefit. All surgery, of course, has some level of risk. Luckily, deep brain stimulation's super low risk, but there's no reason to take a risk unless we're sure there's going to be a benefit. And so when somebody comes in, we have to make sure that they've had a diagnosis of Parkinson's disease, usually for about 5 years, so that it doesn't end up being something else that we diagnose too early. They have to be responding to medications. And we want to see which symptoms are improving and which ones aren't. They have to go undergo neuropsychological testing and special MRI. And all of those things together, then we meet with the neurologists and our nurse practitioners, and we have this large meeting and discuss the patients behind their back and say, okay, this is a good candidate. Once that meeting has taken place, you can almost guarantee that they're going to be a good responder, that the deep brain stimulation is going to make a big difference in their life. And so it is quite a workup, but it's for the patient's benefit.
So exactly what do you do?
So for deep brain stimulation, I think of it as jamming or affecting this abnormal circuit in the brain. And so the problem in Parkinson's disease is that the neurons are not communicating properly because they don't have enough of the fuel, if you will, to make those communications smooth, dopamine. And so they get this abnormal electrical signal in the brain that we can block or alter in some way with an electrode in the brain. So we've got to put it in there, and we have to do that with surgery. And so we don't cut anybody's hair, we don't shave heads or anything like that. We have a patient on the operating table, and in most cases, they're actually awake. That really freaks people out sometimes, and understandably. But Anna can tell you that it's actually not that big of a deal. Your skin, we numb up, but you can't feel your own skull, and you can't feel your own brain either. So most of the time, we're sitting there chatting during the operation. Oh,
let me ask you, is the reason that's done and you don't put the person under anesthesia is you want to be able to see a reaction from them during this process, and that gives you information about how you're doing?
Exactly. It's for two main reasons. Number one is that oftentimes we want to do something called microelectrode recording, but that's essentially just listening to the various frequencies of the brain. It all sounds like static to the average person, but to our trained ears, we can hear where we are in the brain, and we use that information to refine the map being the MRI. And so then now we're talking about implanting the electrode into an area the size of a millimeter. And, in this location, millimeters matter. The second reason is so that once we have it in place, we'll actually turn it on and test it out. And so, prior to turning it on, somebody might be very stiff and very, very slow. And the moment we turn it on, they're putting their hand up in the air and looking at it and going super smoothly. And then we know we're in the right location. So it's the ability to kind of take it for a test drive before we close the incision that makes it very safe and very effective.
And then this is self-functioning. It goes for a couple of years before you have to come back and redo this, if you want to use that word.
Well, actually, the implant stays in forever. So that part, as interesting as it might be, she probably wouldn't want to go through it again. And
I don't mind. If I have to go again, I'll go. Let's go.
In some people, or in all people, we use a battery that, provides the stimulus. That needs to be replaced every 3 to 5 years. Although we were just chatting before this that now there are rechargeable options that don't ever have to be replaced.
Okay, so what happened? You came out, and what difference did you see?
I have a life. I was not living. I was just miserable. It's just like a soul in a sack of potatoes that was so heavy and so hard to move and everything that I just didn't have a life. When it came out, I thought it was going to take me longer, but it was just like probably a couple days left. After a couple days after the surgery, it just felt like I'm born again. It's a miracle. So that's what I say. If I have to do it again, let's go.
What have we done in terms of the technology where the patient can actually be a part of this process in monitoring how they're doing on a daily basis?
So the patient is provided with kind of a rudimentary programmer. They can turn it on and off. And many of the companies that make these devices have the ability to actually change the settings within a range that's specified by the doctor. And so, once you tune it in and get the exact amount of stimulation and the amplitude and the frequency, all these little settings that feels good to the patient, there's really no reason to tinker with it. But the technology has improved now that there's even things like remote programming, so that if I did this on somebody who is from South America, their neurologist could log in to their system from another country and, be on FaceTime or a video chat and say, okay, does this feel better or does this feel better? And they can program it from afar, which I think is really interesting advancement in the technology. And then there has been improvements also in the hardware on my side to be able to direct that stimulation in one place or another so that you can capture more neurons in this area and get the effect that you want, or more importantly, avoid any of the side effects that you don't want.
What are your thoughts about, in essence, turning over this type of care to your patients?
So, I want them to be heavily involved. And I can tell you that in clinic, I spend probably too much time, because I'm always running behind, discussing the diagnosis, discussing the procedure in great detail so that there's no surprises. Number one, I think that's the right thing to do. And number two is that I think it provides a level of comfort and trust that, you're putting your brain literally in somebody else's hands. And so I think it's important to involve them in every aspect of it. As far as the stimulation is afterwards, I hope that we reach a point where they don't need to be thinking about it. We were just chatting. It's like the ideal outcome here is that we implant the deep brain stimulator and then they don't have to think about it, like somebody who has to take pills 8 times a day or check their blood glucose, 10 times a day or whatever it may be. That's a low quality of life. The high quality of life is to use a commercial, set it and forget it,
Right.
And so that's what we're aiming for.
And for people, as we're educating, and you're educating all of us today, when it comes to the noticeable things that those of us that are lay people know about Parkinson's disease, what is its impact on that? Tremors, other types of things like that?
So those 4 things that I listed, tremor, rigidity, slow movements or akinesia, and imbalance, the first 3 are very well treated by deep brain stimulation. We have some choice as to where we place it. There's 2 main targets in the brain. I won't get into all those details, but part of that meeting when we're discussing, okay, is this person a good candidate? Once we say yes, we say, okay, now where are we going to put it? The subthalamic nucleus, or the globus pallidus, all this nerdy stuff, that we can choose a target that might be better suited for that particular patient. And so that's kind of where we...
Very quickly on the age, because, Anna's only 19 years old.
Thank you,
so
sir.
therefore, with a patient that is as young as her, we associate this with older people. So where are we with the research in Parkinson's that cuts across age, not only limits, but where it is in general?
So for Parkinson's research, there's a lot that goes into it. I would say the more exciting thing to me when I'm reading journal articles is figuring out the causes, because if we can avoid, certain environmental exposures, certain activities, et cetera, that lead to Parkinson's, then we don't have to keep searching for better and better cures if it never happens in the first place. But of course, on the end result, when people already have the disease, the research is focused on making medications that are kind of longer lasting or more selective to those particular neurons in the brain. And then on the surgical side, we're always improving the technology there to make it, safer, faster, and more effective.
Anna, you're back on the bike?
Yes, sir. I actually was talking to Dr. Sporrer. We're playing pickleball. I played 3 hours last night.
Oh, awesome.
So, yes, it's fun, super
So
fun.
you've seen a gigantic change.
I was talking to somebody outside earlier. You do know you have Parkinson's and you have the symptoms and you know what you feel. I had pain from like the bottom of my head and base to my feet, everywhere. So you have it, but you don't know how bad it is until somebody in front of you tells you, wow, you look much better. You never know. Parkinson's is one thing, what you feel and what people see. So yes, I'm a new person, and I have new people that I'm grateful for. It's Dr. Sporrer and Dr. Torres and all the team.
So fantastic for you. You've had a great result. Doctor, I'm sure there are many patients who are in similar shoes that have had the same type of results. So congratulations on your technology.
Thank you.
Your education for us today. And I'm sure we'll have you back with the next set of technology where you move this even further forward. But thank you very much to both of you. Well, obviously, this has been a great conversation. And thanks to both of them for sharing this insight with our audience. Remember, viewers out there, be sure to hit that subscribe button on our channel here to keep up with the very latest in health and wellness information and great experts right here to give you good advice. Thanks for watching.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. Baptist Health Talk is brought to you by Baptist Health, the warmer side of care.